So I'm just here today to give you a little chat about some of the new things we're doing in Llanelli and how we're creating a pharmacy service to try to reduce some of the unplanned admissions to Prince Philip Hospital. So what I'll do is I'll discuss sort of frailty as a concept, how we diagnose it. I'll explain about some of the services that we've currently got, SCRAMS, how we're developing this further with this new project 2019, what this means in our practice, and also I'll show you some of the preliminary outcomes and some of our future plans. So what is frailty? There's lots of different diagnoses out there. So it's an age-associated decline in physiologic reserve and function across a multi-organ systems, leading to an increased vulnerability for adverse health outcomes. It's also a distinct health state where a minor event can trigger a major change in health from which the patient may fail to return to their previous level for health, i.e., a slight UTI, delirium, and then they may not recover, that type of thing. It's also, we need to really start classing it as a progressive long-term condition with episodic deteriorations. It also means that patients are sort of less resilient to external stresses. So how do we diagnose it? In practice, it means when patients have significant challenges to their day-to-day living. We also see a deterioration in functional scores. I'll talk about that on the next slide, what we mean by that. But we take it as sort of a combination of at least 3 of the following symptoms. So if they've got weakness, a slow gait speed, unintended weight loss, self-reported exhaustion, low physical activity, depression, or poor grip strength. So if we look at our sort of patient population, between 25 and 50% of patients older than 85 are estimated to be frail. This means there's a substantially increased risk of falls, disability, long-term care, and mortality. This then results in frequent hospital admissions with geriatric syndromes, i.e. falls, immobility, delirium, incontinence, so everyone that's on your sort of geriatric wards. So this is how we diagnose frailty with the scoring systems we see. So 1 being very fit, most of the people in here, to 9, the terminally ill, okay? So in our services, we roughly see people between 4 and 7. 4 being patients when they start to become vulnerable. They often are described being sort of slowed up, getting a bit tired. And then we also see people sort of 5, 6, and then 7. 7 is mainly patients in care homes, which are dependent for all ADLs. So to give you a bit of background, so polypharmacy is more common among older adults due to a high prevalence of chronic conditions that often require multiple medicines for optimal management. We're often asked as pharmacists by some of the doctors and the students, how many medicines does it take at what stage does it become polypharmacy? But in reality, there's sort of no cut-off. It can, cut points of between 5 and 9 medicines are frequently used to define polypharmacy. However, others define polypharmacy as taking a medicine that just lacks an indication, is ineffective, or is duplicating treatment provided by another medicine. Either way, polypharmacy is associated with multiple negative consequences, including increased risk of adverse drug reactions, drug reactions, and mortality. But mainly what we're looking at is how they increase risk of falls in elderly patients, which then can lead to unplanned hospital admissions. So pharmacy teams are ideally placed to help support patients with their medicines and to live independently and stay well at home. So this slide just shows some of the medicines which we target. They sort of increase the risk of falls. I mean, it's pretty obvious, really, but so if we go down diuretics, opioids, everything. But I think sleeping pills, benzos, can increase the risk of falling by 47 to 57%. You'd think when people get referred to us that they may have already had these medicine reviews and that these medicines may have been reduced, but that's not really the case. Another one to highlight is antipsychotic and antidepressants. This is a huge risk of falls, mainly due to their anticholinergic side effects, sort of constipation, their effect on cognition. I think amitriptyline is potentially the most common drug that I've seen to cause falls in our patients. So most falls assessments used in primary care or in admissions or by district nurses include the question, do these patients take formal medicines? This then doesn't lead anywhere. You know, it's supposedly these patients trigger a yes, they need a medicine review. But what I've noticed in my sort of research is this doesn't happen. They're discharged from a minor injuries unit or A&E immediately, and this is just not flagged up to GPs. But the reason why that question is there is because patients aged 65 years or older who have experienced the fall in the last year, the addition of each medicine above 4 increases their risk by 14%. So if we take a look at this in primary care, sort of 17% of patients receive between 5 and 9 medicines, and almost 10% of patients receive 10 or more medicines. So if those patients receiving 10 or more medicines are on the combination of 1, 2, 3, or all 4 of these, this is where polypharmacy becomes problematic. Another area we reviewed during our medicines review was sort of anticholinergic burden. There's been lots of studies recently about the links with anticholinergic medicines and dementia. And I just wanted to highlight one research that's been published in June, sort of using strong anticholinergic medicine every day for 3 years or more is associated with a 50% increased risk of dementia in those aged 55 years or over. So there's lots of different anticholinergic scales out there. We use in our team the Age and Brain Care. I appreciate it's 2012, but it's sort of in a nice format, lots of different versions available. So you've got sort of it's probably quite blurry, but you've got your mild, moderate, and severe. So each medicine's given a score, is calculated, and a person's risk is then worked out. I just wanted to sort of draw your attention to some of those medicines that you may not think have an anticholinergic risk. Things like atenolol, digoxin, I know prednisolone's on there, warfarin. So as you can appreciate, their score does increase quite quickly. So how do we tackle this problem? Where do we begin? So currently, the services that are provided, we've got a frailty clinic running in Prince Philip Hospital in Llanelli. This is a multidisciplinary team. We call it SCRAMS, so it's South Carmarthenshire Rapid Access Multidisciplinary Team. I got there. So it comprises of, we've got geriatric consultants, we've got specialist nurse, specialist physio, specialist OT, and a specialist pharmacist. And on request, we do have a social worker. So who do we see? We see patients between 4 and 7 on the clinical frailty scale. Any patients who've had falls, unexplained weight loss. The criteria are up there. So GPs, our colleagues in secondary care, community staff, they all refer patients into us, and we see them in clinic. So it's now established 5 days a week since September. So during the clinic, we complete a comprehensive geriatrics assessment. So during this assessment, these patients come in, and we see them as a team. So it is a lot of patients, members of staff in one room, but it means that the patient gets a full MOT. So they have a physical assessment, we look at their environment at home, we look at their function, we do a mobility assessment, how they walk, what aids they use. We also do sort of look at their mental state, cognition, memory assessments. And then we conduct a medicine review. So during this medicine review, we look at polypharmacy, deprescribing where possible. But what we were finding was, I think it's quite difficult to do a full medicine review when you've just got the clinic letter. So I've now got remote access to all of the GP surgeries in this area that we're covering. So I think it's about 15. So I've got remote access. So I can access the patient's GP records, clinic letters, and medical notes prior to clinic. I review all of this before the patient comes in. And so I'm better equipped to make sort of recommendations to the consultant on which medicines we can stop, what we can do, and why patients are on these medicines. Is it historic? And this enables me, I've got the GPs have now allowed me, so straight after clinic has happened, I log into the patient's GP record, and I type up everything that's happened in clinic. So what the plan, the individual care plan, any medicine changes, and I can also sort out the scripts as well. So I can change their nomads, issue scripts, sort it out with the community pharmacy. So how do we develop this further? So what other things that we can we provide? So a bit of research was done, and it was found that 50% of patients attending A&E department in Prince Philip Hospital requiring treatment for a fall were readmitted as a medical admission in the following month, which we think is quite a hefty number of patients, really. So what are we going to try and do in the community to reduce the pressure on secondary care and our A&E department? So we've created this community falls, community frailty team. So this comprises of some frailty nurses, myself, and one of the physios. So we've included a pharmacist in this. So what do? So we accept referrals from all of these, the GPs, district nurses, physios, OTs, A&E, but also pharmacists in hospital, and some geriatrics as well. So we discuss these in a weekly MDT. I take my any patients that I think needs a pharmacist review, a medicine review, and I will do a comprehensive medicine review, so either in the patient's home, in a clinic setting, or I can, because of my remote access, I can do it remotely. So just want to talk briefly about the processes involved. So I received my referral using a locally developed form, which mainly looks at patients' access to medicines, their adherence, and their clinical issues. So this form is given out to all of the teams in our Llanelli area, just to give them some pointers to ask during their falls assessment or during their assessment at home. We want to get them to start thinking about medicines, thinking, can I have a look at where you keep your medicines? Have they got these massive cupboards full? Do they need some input, really? So once I do their sort of medicine review, I review their GP records, I will go and see them at home. I do the typical, discuss with the patient, look at what we can de-prescribe, look at their ordering system, just things like that, these little things which perhaps in a hospital setting we may not see. So I discuss then any medicine changes with the GP and the community pharmacy. I then action the changes myself using the systems. This sort of reduces pressure on the GPs and also sort of saves time and money with travelling. So I do the changes, but I can also refer to other services if available. So some of the de-prescribing resources that are out there, there's heaps and heaps. So some of the things that we're using is the stop-start tool. Sort of Prescrip have got some good information. There's an impact document, no tiers, BS criteria, deprescribing.org have got really useful algorithms. These are the type of things we're using during sort of our education to our GPs and our hospital doctors and things. So as you'd appreciate, I've been doing this since January. It's taken quite a lot of time to establish connections and sort of build up and find the service which is needed, really. So far, 94 patients have been referred to myself for a medicine review. Out of those 94, 89 have been counselled in their own home on how to take their medicines, sort of compliance aids started or medicine reminders, things like that. So I've managed to de-prescribe 71 medicines. So on average, this is 0.7 medicine stopped per patient. I appreciate this is a low number, but if we think about not everyone that's been referred to me is for a medicine review with regards to de-prescribing to polypharmacy. We've got also the patients that have been referred to me purely for stockpiling, just a compliance review. So if I looked at the data again and calculated the sort of percentage of medicine stock per patient in those polypharmacy reviews, I think that number would be a lot higher. 5 patients where we started medicines, mainly things like fludrocortisone for postural hypotension, things like that. These things were picked up in the minor injuries unit, but the patient's discharged before anything has been started. I've referred 45 patients to other services, mainly like district nurses for some blood glucose monitoring, things like that. OT for handrails, physiotherapy for strength and exercise work. In 32 patients that I went to see at home, I left there with a lot more things than I went with, mainly bags and bags full of medicines waste, which, if I spent the time to actually work out how much money that is a lot of money. So in 30 medicines, we sort of made a dose change, mainly things like renal, NOAC, on the wrong doses of NOACs, things like that. So on average, just from deprescribing the medicines, we've saved roughly about £5,000, but it's in very early stages. So as you can appreciate, numbers are a bit low at the moment, so I just wanted to give you two examples of things. One is a typical patient that I see in clinic, but also that I see in patients' homes, just regards to falls. So this is Mrs. YL. She's an 81-year-old lady. She attended MIU with a fall. On questioning, she had fallen 5 times in the last year. Obviously, there are her OBs, so she's got a significant postural drop. She was discharged from MIU, but luckily referred to our service. So we went to go and see this lady at home, myself along with one of the fall sisters, chatting to the GP about what we were going to do. We stopped her bendro flumethiazide due to her postural hypotension causing her falls. And we also stopped her simvastatin. There is little to no evidence of using statins over the age of 80. It can also, when patients are using statins over the age of 80, it can increase their risk of cognitive impairment and also myopathy. So when a patient that's falling, these are the things that we really look at to try and sort of reserve muscle bulk and get these patients sort of better. Lots of follow-ups needed with these type of patients, rechecking their blood pressures, because as we appreciate, she's an 81-year-old lady, she lives alone, no families. So our interventions then, we went back, she still had postural drops, we stopped the atenolol until we found no postural drop. We also managed to refer her to the OTs and physio. But the question is, what would have happened if we weren't there as a service? Would she have bounced back from MIU? Would she have been in those 50% of patients being readmitted with a fall? It's really hard to quantify. So, could she have had a fracture? Would she have been in for a month? So it's difficult to prove our worth, but I think quality is where we are. We can safely say this patient, we stopped 3 medicines, brilliant, but long term we're looking at what our service is providing. So the last case I want to just show to you is Mr. RW. I went to see this chap a couple of weeks ago. He's an 84-year-old gentleman. He's a clinical frailty score of 6. It's a history of of multiple falls, poor appetite, functional decline, the general client we see, really. No postural drop, and it was thought the falls were due to sort of his low motivation, low mood. He was a very, very frail chap. This is his medicines, this is what I was faced with. You can see, loads and loads and loads of things wrong. I won't go through them all. But basically, due to, he'd had previous throat cancer, so some of his medicines were in oral dispersible, some were in liquid, some were in a tray. He managed fine with his tray, but, on questioning, he admitted that he wasn't taking any of his oral dispersible or his liquid preps, he was forgetting. Another point up there is his insulin. He hadn't had any since October 2018. And when I said, do you take any insulin? Are you using that? He said, oh yeah, I've got a pen. Let me find it. And it was so out of, it was ridiculously out of date that it was worrying. And he hadn't tested his blood glucose for, he wasn't sure when the last time was. So there's lots of these patients out there. So it's basically like, what can we do? Where do you start? Main point really was we stopped the community pharmacy from ordering when required medicines. He had his community pharmacy would come every month, and he had 3 boxes of stuff every month. So we just stopped doing that. The daughter said she was more than happy to do that for him. We changed the oral dispersibles to tablets, put it into the tray, removed things off repeat that he wasn't taking. We stopped his metformin. He hadn't taken it for weeks and weeks and weeks, and actually his HbA1c was 49. So it was, after discussing with the GP, we stopped that, and we were going to recheck it in 12 weeks. I referred him to the community diabetes team due to the insulin, and he wasn't monitoring any of his blood glucose. We've stopped the atorvastatin because he's an 84-year-old chap with muscle wastage in his legs. No to little evidence for using it, really. And I also referred to the physio. And this was a guy that I removed a lot of medicines from his house. But some of them were sort of MST 30 milligrams, MST 40 milligrams, things that could really cause harm if he were to get more confused and take them. But, and again, what would the impact be if we didn't go? Would he still be, not taking any of his medicines? The money saving, we can't, just visiting this gentleman, spending an afternoon sorting this gentleman out saved almost £800 per year. So the savings are there if you're looking for money, but we're looking at the quality of service that we're providing. So what does this mean in practice? We're going to continue to educate everyone around us about the importance of medicines, safe medicines use, but also compliance, polypharmacy, deprescribing. So I've been teaching some of the junior doctors recently, some of the hospital pharmacists, and myself and a colleague have been teaching the non-medical prescribers on the importance of deprescribing, what tools are out there. So we're going to continue to do so. We just really need to do, educate around problematic pharmacy. At what stage does polypharmacy become problematic? We need to remember that guidelines are guidelines and they're there to guide us, but we also need to use our clinical judgment. We just need to think carefully before initiating any medicines in this group of patients, exploring alternatives, especially with anticholinergics and patients with cognitive issues. We need to explain the risks to patients and obviously arrange routine drug review after initiation. But this is the message I'm giving everybody, is to involve pharmacists in medication review. There's enough of us out there in primary care, secondary care, so we just need to start involving pharmacists in the medication reviews. So what does this mean for the future? We're going to keep sort of team working to tackle the barriers and improve medicines during care transition. There's a lot of problems between sort of primary care to secondary care, or when patients are discharged, they're not counselled on their medicines perhaps, or they are and then they forget. So we're trying to improve and sort of tackle that. We'd like to establish a pharmacy team to expand the service. Currently, it's just me, sort of 4 afternoons a week doing sort of this. So that would be great. So potentially some more pharmacy time. It'd be great to have a technician to do some of the, the counselling and explore other options. But yeah, we just need to continue to support and educate GPs, junior doctors, hospital pharmacy teams to really take onus of this and challenge doctors to do these medicine reviews. I think in the future we do want to sort of work with the other Hywel Dda hospital sites to replicate the service across the whole of Hywel Dda. But yeah, the question remains sort of how do we prove it and how do we prove quality? We know it works. Well, I'd like to think I'm doing something that works, but how do we prove it? But yeah, thank you for listening. Yeah, thanks.